All right, this is a real treat for me. I've kind of followed the Society of Mechanical Ventilation from a distance. I'm come from Rochester, Minnesota, and Eb and I had connected through email a while back.
So just trying to get you into the picture.
Oh, in the picture. Oh, my face.
That's good.
That's okay. We don't need that.
Well,
Yeah. We want a good presentation here. Yeah. So my name is Ben Daxon. Just brief introduction for me. So I'm coming from Mayo Clinic. I should qualify what you're about to hear in no way as official Mayo Clinic practice. I'm kind of the black sheep of the family up there. Maybe you'll see why in a few minutes. But I'm the medical director for surgical ICU. I'm the program director for anesthesia critical care medicine fellowship. And before I kind of get into the nuts and bolts of everything, just so I understand who I'm talking to and can kind of tailor what I say. Has anybody here used APRV in the last year? Oh, wow, that's more than I thought it would be. Okay. Has anybody not used APRV in the last year? Okay, we got one. Okay, great. And number of respiratory therapists? Oh, wow. Okay. All right. Well, okay, great. So I'm going to assume a more sophistication from this audience than I typically would. I'm going to skip over some traditional introductory slides. In my experience, the best conversations about airway pressure release ventilation, APRV, happen not at a podium in a big conference room, but they're one-on-one at a bedside. So I'm here all day today. I'm here all day tomorrow. I'm sure I will say something that you're going to scratch your head at or go, no, that's wrong. He's ridiculous. That's not true. Just find me later. I'm happy to tell you why I'm right and you're wrong. Okay. That was a joke for those that didn't laugh. All right. And I should say, I'm an Apple guy living in a Windows world, and we're going to see if we can make this presentation work. And I think you're going to have to bear with me as I scroll through it. We're going to lose a couple of videos, but that's just the way it is. So I'm going to skip over kind of what usually is APRV. This is how you set it. This is what the waveform looks like. I'm going to try and talk about some underappreciated aspects of the mode, and there's four we're going to talk about. One is recruiting. I think people understand that APRV recruits, but I don't think they understand the same way that I do, and so we'll talk about that. We'll talk about cardiogenic mixing and improved ventilation with APRV. I think most people look at APRV as an oxygenation supporter. I'm going to talk about its benefits for ventilation. We'll then talk about secretion clearance, everybody's favorite topic, and then I'm going to talk about APRV in a clinical context with lung transplantation. It's some really obscure studies here, but quite interesting. So the first thing, I have to do a little throat clearing. Not everything is APRV. Oh, I'm sorry, this isn't going to get the whole screen up on the slide. This was a nice review article. It showed 35 years of APRV use, and here are four different trials that used APRV, and these are all considered the same thing. They're all described as APRV, but these are drastically different ways to ventilate. If I was using this way to ventilate down here in the bottom right corner, and you were using this way over here in the bottom left corner, and we showed this to a third person, that third person would not think we're doing the same thing. But all this gets lumped together as if it's synonymous, but obviously it's not. So the way that I'm going to be advocating for using airway pressure release ventilation is by following a protocol called time-controlled adaptive ventilation, or TCAP. For those of you who are familiar with it, this should be a familiar slide. But you basically have a very prolonged time at your high pressure, a very, very short time at your low pressure, and it is always set to 0. And the secret sauce is setting the time at that pressure of 0 appropriately based on the expiratory flow. All right. Hopefully that's enough of an introduction. I'm happy to go into the weeds on TCAP and how you set the mode. Again, I'm going to assume some sophistication from the audience here. Find me afterwards if you need more explanation on this. All right, so let's talk about those four things. First is recruitment and using time instead of pressure to recruit the lung. So normally when we recruit, I should say there's 1,000 different ways to recruit. I'm an anesthesiologist, so the way you do it in the operating room is you switch the PEEP valve and you just hold the pressure for about 10 seconds. And we typically don't do more than 10 seconds of recruitment maneuver, because after 10 seconds, the juice isn't worth the squeeze, right? You start getting hemodynamic effects. The volume that you recruit goes significantly down. I mean, most of the volume that you recruit is in the first 2 seconds, and then a little bit more in the subsequent 8, so that first 10. And then thereafter, it's really not that much, okay? But This isn't going to work. This is going to be a beautiful slide. This is where we lose the formatting here. So there's a nice little video. This has made its way on Twitter and social media. So if you've seen it, you know what this looks like. But if you were to hold a recruitment maneuver past that 10 seconds, you still do recruit lung. It's not what you get in the first couple of seconds, but it's not something to ignore. And so what I would propose to you all is that what if instead of a 10-second recruitment maneuver, you did that for 10 minutes? And what if instead of 10 minutes, you did that for 10 hours? And what if instead of 10 hours, you would do it for 10 days, right? Like eventually you're going to recruit the lung. It's just a matter of time. Now, we don't do this because at some point you have to release the pressure and let ventilation occur. But that's exactly what we're doing with APRV following a TCAP approach. We have a prolonged time at this high pressure and a very, very short release phase. And it's so short, you don't allow any of the recruitment that you had previously achieved with your extended time at that high pressure. You don't lose any of it, you sustain it. And so you keep adding on these periods of high pressure. And what it amounts to is what someone on Twitter once described as a recruitment maneuver that doesn't quit. It just continues to go. Yes, but Dr. Daxon, what are you talking about? We had the ART trial. We know this doesn't work. We don't do recruitment maneuvers. We've got guidelines to say, don't do it, right? This is the big boogeyman nowadays. Well, just as I showed you in that initial slide that not all things are APRV, not all things are recruitment maneuvers. Here's several different noteworthy articles that have come out bashing APRV, bashing recruitment maneuvers, basically saying open lung approach is closed. The door is closed on the open lung approach. But all these, there's lots of different recruitment maneuvers. And again, we're doing the same thing that we did with that first slide in APRV, where we lump all these recruitment maneuvers together as if they're synonymous, but there's not. There's, like I said, a 10-second hold, there's a 40-second hold, there's stair step up, there's stair step down. There's lots of different ways you can do this. There's our Hamilton, we've got our PV loop tool in there. We actually do that quite a bit at Mayo, unless we're in APRV. So what's different with APRV? As opposed to all of these, I would posit this, that APRV has a very unique approach to recruiting, and that in all these other recruitment maneuvers, what we're doing is we're blasting the lung with a bunch of pressure for a little bit of time. And APRV is sometimes described as upside down ventilation, and you typically have to think about things in a reverse way. And here's one example. APRV does a recruitment maneuver, but it turns it on its head. Instead of a bunch of pressure for a little bit of time, you have a lot of time with just a little bit of increase in your mean airway pressure, or actually no difference in your plateau pressure. So with those initial settings, you take your P high and set it to the plateau pressure of the previous mode, and then you just leave it there for an extended period of time, 10 minutes, 10 hours, 10 days. And so this is a drastically different way to recruit. And I think when you lump APRV recruiting in this manner with all of the other traditional ways we recruit, I think that's a really apples and orange comparison. So when you do this, APRV takes advantage of what we can call viscoelastic creep. Talking about the viscoelastic properties of the lung is a completely separate lecture. Again, I'm happy to get in the weeds on that. But there are some interesting facets to the architecture of the lung, the way the elastic structures are distributed throughout the lung, and how this pressure for an extended period of time is able to take advantage of that with APRV that you don't get in other traditional recruitment maneuvers. So again, with APRV, you've got this extended time without a change in your pressure. You do have an increase in your mean airway pressure, but an extended time at that same plateau pressure. And what you end up getting is a slow, gentle, and judicious recruitment maneuver. And here's just one interesting case report. This was a patient that was on ECMO for 30 days. And before I get into the case, I should qualify. I am not saying that APRV will recruit everyone. Very important. ARDS can enter a fibroproliferative phase. APRV is not magic. You don't just put those 4 letters on the top of the ventilator and suddenly the lung is recruited, right? However, if I told you that I had a patient who was on ECMO, VV ECMO for 30 days, their lungs had been whited out, it had been a long, terrible slog, and we were going to be having our prolonged vent weaning discussion, and I said, hey, hold my beer, watch this, and I put him on APRV and told you I was going to recruit him in 24 hours, you'd be like, this guy is... we need to rethink his medical license. But sure enough, that's what happened here. After 30 days on ECMO, we had a patient with a PF ratio of 75, and after 2 days, went to a PF ratio of 275. The images aren't the best, but you have dramatically recruited lung volume here, and I've just clipped out 2 pictures from the case report, but this patient subsequently went on to be extubated after being on TCAP for about 5 days, so just quite remarkable. All right, so that's recruiting. Let's talk about cardiogenic mixing and improved ventilation. Sorry, the formatting's ruined here. All right, so when we do traditional ventilation, we have bulk ventilation. We have a big volume of air, move it into the lung, big volume of air comes out. But APRV has this extended period of time where if the patient's not spontaneously breathing, you're just holding that high pressure. And during that time, you actually have ventilation that's occurring. It's just not one that you see because it's occurring deep down in the lungs. Deep down in the lungs at the alveolar level, you're still having gas exchange, diffusion of CO2 out of the blood into the alveoli and oxygen into the blood. And when you get to the end of that extended time at your P high and you have another release where there's bulk ventilation, what you've effectively done is reduce the amount of dead space. You've allowed CO2 to creep up the respiratory tree so that when you do have a subsequent release, the amount of CO2 that you're expelling is greater than if you'd just been doing bulk ventilation in between each one of those breaths, right? So the reason why this occurs is because you're taking advantage of something called cardiogenic mixing. And this has been looked at, again, this would be such a great presentation of these videos. So some researchers looked at some, I believe, mouse models, and they showed that when the heart is beating, it's agitating all of the structures around it. And so basically you have an internal oscillator that helps agitate the air, move CO2 down its concentration gradient, and it promotes this cardiogenic mixing. However, this does not occur in the presence of bulk airflow movement. So once you start moving air in and out, you really lose this feature of physiology. But if you can hold the time there for a little bit, heart agitates, moves CO2. When you have the subsequent release, you have decreased dead space, more CO2 is expelled. So it's a very neat aspect of the way this breath profile works. A couple things to note about this. This really only works in the areas adjacent to the heart, particularly the dorsal region. So if you have socked-in lungs, as you typically see in ARDS in the dorsal region, you're not going to get as much bang for your buck here. But again, if you can use APRV and recruit that lung back, you will take advantage of this, okay? When you look at the mouse models and extrapolate to humans, the amount of cardiogenic mixing is going to vary depending on a lot of factors, but it could be up to 53 milliliters of CO2 that you're expelling. Or another way to think about it, you can reduce your tidal volume by 53 milliliters and have the same amount of effective minute ventilation. Here's one interesting study. This is one of my favorite studies in all of mechanical ventilation. I've never really seen this talked about. It's a very clever study. These investigators took all of the, what I call wasted time at the end of exhalation where there's no gas flow, and they took all that time and they added it to the inspiratory side with a prolonged inspiratory pause. And so they ended up adding 0.7 seconds on average to the inspiratory time on all these breaths. And what they found, again, here we go. So they changed their breath profile from something like this to something like this. And again, when I use inspiratory pauses in the ICU, I'm typically doing it for an oxygenation standpoint. I don't know how common you guys do a 0.2 or 0.3 second inspiratory pause, but here they're adding a 0.7 second inspiratory pause. And you would think, well, that'd be great for oxygenation. But what they found in this study was, yes, there was improved oxygenation, but there was a significant decrease in the PaCO2 without any change in the respiratory rate, without any change in the tidal volume, and a significant decrease in the amount of dead space. And what they were able to subsequently do was then, because they had more effective ventilation, they were able to decrease their tidal volumes by 0.7 milliliters per kilogram and their driving pressure by 2.5 centimeters of water. Oxygenation is great, but CO2 also has correlations with mortality, and what they're showing here is decreased driving pressure, decreased tidal volume, because you have prolonged time at that higher inspiratory pressure. And I don't think we think in those terms that often, at least I didn't until I read the study. Now, if you're really creative and you squint and you look at the way these waveforms are panning out, you can kind of see that if you extend it a little further, we're getting closer to what an APRV waveform profile would look like. So again, in most people's minds, APRV, it's great for oxygenation. It's always a CO2 problem. But here we've got some mechanisms to explain that APRV can actually be more efficient in how we handle our CO2. And if you actually go back and look at our trials, and there's not many, but those that have looked at APRV, I'll give you one here, show that we've got improved CO2 handling with APRV. In this paper from 2010 by Maxwell, I just want to quote him here. It says, perhaps the most interesting finding of this study is that despite having significantly higher minute ventilation, the lung protective patients, low tidal volume patients, had higher PaCO2 values. Increased mean airway pressure may in fact improve recruitment, which in turn would increase FRC and gas exchange. PaCO2 is therefore reduced at lower levels of minute ventilation. I don't know where you fall on the love-hate spectrum of APRV, but everybody can get behind that, right? If you can decrease your PaCO2 with lower minute ventilation, that's a great thing. One study looked at a retrospective look at APRV's ventilatory ratio. It's the only study we have on this. And again, not surprising given what I've told you for the last 5 minutes, showed a decreased ventilatory ratio with patients that have been switched over to APRV. Maybe you could say, well, they were improving anyway, and it was going to cause that. Again, I don't want to hang my hat on this one study, but it's just another chip on the scale that APRV, despite all the naysayers saying it has horrible issues with CO2, can actually improve your ventilation. And again, when you look at the studies, our ZOO trial from 2017, Ibarra Estrada in 2022, another trial here from 2021, in all these studies, you've got a decrease in your minute ventilation, and the same or a decrease in your PaCO2. And when you compare the APRV arm to the lung protective low tidal volume control arms in these studies, here you can see that they've got a similar minute ventilation and an increase in CO2, or an increase in minute ventilation and a decrease in CO2, but it's drastically different from APRV. You're getting decreased minute ventilation with simultaneous decreased PaCO2 in your APRV arms that you don't get in your low tidal volume arms. All right, moving on. You talked about being, okay, good. I think I don't want to be the guy that keeps us late. All right, so secretion clearance. This is, I've never heard anybody talk about this. I think this is super fascinating. And if you haven't heard it before, here it is, first time, and you're going to take this back to your practice. Very clever study that trying to look, before I get to the study. In my experience, this is anecdotal, this is not robust data here. I always tell someone, if you really want to clear out pulmonary edema, the best thing you can do, prone your patient and put them on APRV and tell the nurse to get ready. And I have seen that happen time and time again, and I knew it anecdotally, I knew it intrinsically, but I didn't have a good mechanistic reason for why. I didn't have any studies to back it up, and then I had this one. So this was a group that looked at simulated mucus. So they took some gum. There's a whole. They listed in the trial the recipe for making simulated mucus. It's I encourage you all to try and make your own simulated mucus someday. But they wanted to look at what happened to mucus in the respiratory tree on various settings on lung protective ventilation. And so they've got various PEEP levels here, just different ARDSNet protocols. And these bars represent inspiratory and expiratory flows. And it doesn't matter what the inspiratory, expiratory flows are, it doesn't matter what the settings are. On this y-axis over here, this is supposed to represent your mucus secretion, how much mucus is expelled out of the lung. And as you can see, there's no green dots going up on the y-axis here. In other words, all the mucus stays in the lung, or even worse, it's getting pushed back into the lung. And then they flip them over to APRV. You remember I told you that APRV is upside down ventilation, and so we switch the pressure and time. Well, similarly, we also switch the inspiratory and expiratory flows. And when you get into APRV, your expiratory flows are much faster than your inspiratory flows. And depending on how you set the mode, much faster. And so what they found is that now with APRV, we have faster expiratory flows than inspiratory flows. And as they reduce the P-low from 10, 5 to 0, they got more and more expulsion of secretions out of the lung. So you have this super fast exhalation, and then not as fast of an inspiratory flow. And so mucus moves out 2 steps, back in 1 step, out 2 steps, in 1 step. And over time, you get this stair-step expulsion of secretions. This is too clever, right? That can't be true. So just so you guys can see it, it's not going to work because we don't have the videos. That's right, we're PDF. All right, so they've got videos online, intensive care online, if you wanted to go back and see these videos. Very clever, and you can see the green stuff moving out of their simulated respiratory tree. But it's too clever, so I thought that can't be true. So our respiratory therapy students at Mayo, we actually repeated this study, and here's our mucus. We dyed it green. We thought that would be fun. And so we put mucus in an endotracheal tube. Again, tried different APRV settings, tried different PEEP settings here on lung protective traditional settings. And sure enough, in our APRV arm, depending on how we set it, with P-low being the best, it moved the green goo slowly out of the endotracheal tube. It's not fast. I mean, this is only a 2-minute study, but nonetheless, we could see it just, working its way like a slug up the endotracheal tube. But with the other modes, not only did it not move out, it actually moved back in. And so in your traditional ventilation, your faster inspiratory flows and expiratory flows, I think, are in some ways actually driving back the mucus and other respiratory secretions back into the alveoli, which obviously is not where we want them to be. We want them expunged. All right. I got 5 more minutes. Lung transplant. This is an overlooked area, but it's really interesting. And I like lung transplant because it puts to rest, in my mind, the debate about, well, should patients breathe spontaneously or not? Well, it depends. But here's a great example where you have brain dead donors who are going to be put on APRV. If there is a group of patients that is not going to be breathing spontaneously, it is going to be our brain dead donors here, right? So in this study back from 2010, 2012, they looked at their use of APRV in their lung donor population. And what they found that their APRV patients were in general younger, but they were also a lot sicker. They had a lower PF ratio than the standard ventilatory patients. And what they found with these APRV lungs after they had been transplanted, that at the end of their time on APRV, so before you explant the lung, you take it out and you transplant to somebody, you do a 100% FiO2 challenge and you see what their PF ratio is. And when they did that, there was a significantly higher PF ratio for all the patients that have been ventilated on APRV. I'm going to guess maybe it's because we recruited, because we got rid of their respiratory secretions, right? All the things we've been talking about. And then when you looked at those lungs 1 and 3 years after they had been transplanted, they had almost statistically significant, I should say, a trend towards improved mortality. Now we've got 25 and 20. This isn't powered to be a mortality study, but that's a pretty significant p-value for the N being as low as it is. Interestingly, I called Dr. Hanna years ago when I had first read this just to get his take on all of it. And he said, oh, I love APRV. I think it's amazing, but we don't use it anymore. I said, why don't you use it? You have this incredible data. He said, oh, I can't tell you how many gray hairs I have from fighting everybody on using APRV in our lung transplant patients. So interestingly, this group no longer uses APRV for their lung transplants, despite that volume. Here's one other study on APRV and lung transplants. This is an obscure study. I've never seen it cited anywhere else. This is St. John's out of Phoenix. They looked at all of their APRV patients over a period of time and found that the patient's lungs that had been put on APRV prior to being explanted, prior to getting to them, were older, fatter, they'd been on the ventilation longer, and they were just sicker. There was more chest trauma in those patients, right? So the deck is stacked against APRV doing well in their transplants. But despite that, they had a trend towards improved outcomes with all of their APRV lungs. And APRV is actually the majority of the lungs, at least years ago it was. Again, I called up these researchers to try and understand this better. And they said there were these lungs coming out of Los Angeles that were ventilated with APRV. Nobody wanted them because they were ventilated with APRV. Chest x-ray looked good. PF ratio looked good. All of the values said they're fit to transplant, so let's just transplant them. And they found that their APRV lungs were typically better, and that they ended up being one of the few people that would use them. And so they ended up just saying, give us all your APRV lungs, we'll take them. And then they ended up having better post-transplant courses with them. All right, so I think we're hitting our time. So I've talked about recruiting, how APRV is upside down ventilation. We have this extended time and not a blast of pressure that gently, judiciously, methodically recruits the lung. We've talked about cardiogenic mixing and how that waveform following a TCAP protocol allows for cardiogenic mixing, that the heart could agitate the CO2, decrease dead space, you expel more CO2 with each breath. We've talked about secretion clearance, again, the upside down ventilation, these faster expiratory flows expunge secretions from the respiratory tract. And then I've also talked a little bit about APRV in lung transplants. In a patient population, I don't think most would consider the ideal group to try APRV in, yet the literature we do have, not robust, but does suggest that there are improved outcomes with APRV. And with that, I want to close with one final thought. This is a preview for our debate. I shouldn't say debate, pro-con discussion, let's call it that. I've just given you a couple interesting things to think about APRV. I'm an APRV guy. I'll tell you it's great. I think it's great, but I'm not going to say everybody should just use it willy-nilly. It's not magic, right? APRV is only a tool. I will also tell you that don't let the beard fool you. I used to be on active duty with the Army, and I would shave every day. I never made it up to tripler, unfortunately, but I would tell you that, well, I'll ask the men in the room. If you wanted the best shave of your life, what would you do? That's a real question. What would anybody? Yeah, I think somebody said you'd find that old school barber. And what would that old school barber do? He'd whip out that straight razor, you'd lie back, you have the hot towel, the oil, and all that stuff. But you take that tool and he would give you the best shave of your life, right? Now, what if you wanted the worst shave of your life? It's a real question. What would you do? A big, yeah. You would get, I would tell you, you would get that exact same straight razor. How many men here have ever done a straight, or women for that matter, have done a straight razor shave? Yeah, we've got some olds in the back. Yeah, so I'll tell you, I had a German straight razor when I was in the Army, and I butchered my face trying to learn how to do that. But the point is, you can get the best shave and the worst shave with the exact same tool. It all depends on how you use it. And what I will tell you is that there are a lot of very interesting aspects to APRV. I think if used appropriately, it is by far the best way we can ventilate our ARDS patients. However, it's also one of the worst ways you can ventilate if you don't know what you're doing and you muck up the settings and you hurt your patients. And with that, I'll hand the floor back. Questions? How different questions?
Thank you so much. That was great. If you have any questions, yes, might have one or two.
Yes.
By the way, we're gonna have another discussion or the debate whether you hate it or love it, so you can.
Sir, something like that, just one more. See it.
So I heard about half the words in there. Have we put?
Have you done your own research on if you're up against something like the DDR, which is a high frequency? You have CO2 removal, you want control of your mouth pressures, more of unprotected ventilation.
We've got a new respiratory therapy class, so it's a good one to follow up that study with. So yeah.
Yeah, I think to my knowledge, there is no comparison. There wasn't trials comparing the APRV to whether the VDR or the high frequency.
Oh.
I actually tried to do one years ago during the H1N1.
Oh.
Okay. Oh, yes, sir.
I had a similar question along the same line. You mentioned about cardiogenic fixing and using the benefits of cardiac. What are your thoughts on introducing IPPV for the same benefits?
No, I'm lucky if I get to if I can convince people to use the mode as is. So I try not to get too fancy if I'm going to use APRV. It's enough of a mental lift for people to try and understand the basics. To add on other things, it just complicates it further. I'd love to try that. I'd love to try a number of different things, but you'll get theoretical answers from me, and then you'll get practical answers from me. I'm giving you the practical ones. I wouldn't do that just because I'm trying to keep it as simple and understandable, because I have to share the mode with so many other people at the same time. So that's a good thought. Thank you all. I'm here all day. If you have other questions, just come find me. Thank you.